and welcome to Grand Street Rounds. I'm your host, Dr. Carly McMillan, and I'm the CEO and founder of Brooklyn Minds. We're a comprehensive mental health center based in New York City. We specialize in treating patients as a team for whom more traditional psychiatric help, such as the heavy use of frequent hospitalizations and crisis ER visits, has often been counterproductive. Grand Rounds, for those who don't work in medicine, originated as part of residency training to share new information and enhance clinical reasoning skills. Grand Rounds help keep people up to date on bigger picture ideas that may be out of someone else's area of expertise. Grand Street, for those who haven't visited our Williamsburg flagship office, is our first permanent home, so the mashup was a natural fit. Today, we welcome one of our psychiatrists, Dr. Amanda Tinkelman, to speak on disparities in perinatal mental health. Amanda previously served as the physician in charge of perinatal programs at Northwell Health's Zucker Hillside Hospital, where she helped to grow a robust clinical outpatient perinatal psychiatry program, as well as build a new perinatal inpatient psychiatry program. Dr. Tinkelman is an assistant professor of psychiatry at the Hofstra Northwell School of Medicine. She presents on a national and international level on topics related to perinatal mental health, and is a recognized leader in the field. Before we begin, just a reminder, content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your mental health professional or other qualified health provider with any questions you may have regarding your condition. So following Dr. Tinkelman's presentation, we'll have a question and answer, and we encourage you to submit your questions and comments either directly to me, or you can do it in the chat as well. So welcome everyone, thanks for being here. And all right, Dr. Tinkelman, the Zoom is yours.
Hey, thank you, Dr. McMillan, for hosting this Grand Street Rounds series, and thank you for inviting me to speak on this topic. It's a timely topic, and perinatal mood and anxiety disorders is a topic that I'm very passionate about. So I will start by sharing my screen here. Forgive the technology delays. Okay, so today I get to talk to you about disparities in perinatal mental health. And as a disclaimer before I start, and I do this often when I speak about perinatal mood and anxiety disorders or perinatal mental health in general, I'm going to say a couple things as disclaimers. One is I'm very passionate about this topic, so that makes me tend to talk a lot. So I apologize if I end up, sort of going on about something. I blame my passion. And the second disclaimer is that this literature as a whole most of the research uses very cisnormative language. So as I am speaking, you'll hear me talk a lot about mothers and women, when probably more authentically the literature should have referred to birthing parents or pregnant person. However, I will refer to what the literature says, and I'm not as consistent as I could be, and I will be working on that. Okay. All right, so the goals of today's topic are multiple. I'd like to use this opportunity to raise awareness about the overall prevalence of perinatal mood and anxiety disorders, how common they are, how undertreated they are, and the problems around that. I also, the main point is to acknowledge the stark racial disparities in maternal mental health, especially impacting the Black community. Given the time that we have, I'm going to be focusing mostly on comparisons between Black and white birthing people and the disparities that we see within the Black community, and the interactions with overall maternal health, meaning like maternal and infant mortality and things like that. I'll touch briefly on how this time period is likely one of the multiple biological mechanisms. Of course, there are cultural mechanisms too, but for the transmission of intergenerational trauma. We will be able to, by the end of it, hopefully identify at least 3 forces of oppression and discrimination that interact to produce poor outcomes. And finally, to end on a more hopeful note, I'd like to discuss models of care, interventions, and best practices. And in doing so, I hope to amplify the voices and work of the people who have really dedicated their careers to bridging this gap. It's my honor to learn from them, and I would like to promote all of the work that they're doing and really showcase the amazing work that's being done, and the hope that that gives me and hopefully gives all of us in the future. And at the end, there'll be a list of a lot of resources for further education and initiatives to support. Okay, so I guess let's start by just talking about, we'll define some terms. What do we mean by perinatal? Perinatal refers to the time period around birth. And in practice, this includes all the way from preconception planning, pre-pregnancy, including perhaps struggles with infertility, the time period of being pregnant. It includes perinatal loss, miscarriage, stillbirth, or death of a newborn. And it extends postpartum, usually up until about 1 year, although it might be longer if the person is nursing. So a well-known and common perinatal mental health concern is, of course, postpartum depression. Most people know about postpartum depression. And I want to be clear that we're not just talking about depression here. Major depressive disorder is certainly a frequent mental health diagnosis around the perinatal period, but birthing people are at risk for suffering from many different disorders, not just depression. And these are collectively referred to as perinatal mood and anxiety disorders. And you can see from the list that they include diagnoses such as, in addition to MDD, major depressive disorder, generalized anxiety disorder, OCD, panic disorder, PTSD is actually quite a common one, bipolar disorders, and psychosis. So it's not only depression, and it's also not only postpartum. Many PMADs begin either even before pregnancy or during pregnancy. So I say that only to sort of broaden the scope from what most people think of when they think of perinatal mental health, and they think sort of only of postpartum depression. Okay, so the new term that we'll be using throughout this talk is perinatal mood and anxiety disorders. All right, they are really common. This infographic is from the Blue Dot Project, which is one of the resources in the back that I would recommend people check out as sort of an educational and advocacy initiative. 1 in 5, in this case, the data says women will suffer from a maternal mental health disorder like postpartum depression. That's very common, right? It's a very common complication of childbirth, and in fact is the most common complication of childbirth, to have a mental health disorder complicating the perinatal period. Shockingly and sadly, less than 15% of those women will receive treatment for that disorder. 1 in 7 will have a depressive disorder, it being one of the more common ones. And if you look at certain populations, for example, women who are living in poverty, the rates can be as high as 50%. And these disorders don't just affect the moms, they impact the whole family. It's just massive, the scale of illness that happens around childbirth that generally has been sort of overlooked. And there's some concern that perhaps the incidence might be increasing over future years, as we have been seeing an increase in rates of anxiety and depression in teen girls, and having anxiety or depression earlier in your life is a risk factor. By the way, 1 in 10 dads will also experience a perinatal mental health disorder following the birth of their child. Okay, so it is common at baseline. It is more common in certain populations. So if we look at women of color and also low-income women, which are partially overlapping spheres, they're not synonymous, both groups are much more likely to suffer from perinatal mental illness and be less likely to receive treatment. So this is what we would call a disparity, right? So if we're looking now to shift to Black birthing people versus the entire population of birthing people, rates for Black women for developing PMADs were 38%, and that's as opposed to 14% for all postpartum. Black women were less likely to express feelings of depression or anxiety, but suffer higher rates of depression and anxiety than their white counterparts. Or in contrast, you could conclude that white people are more likely to express feelings of depression or anxiety relative to the score on the rating scale. Black and Latina women less likely than white women to be screened, to seek treatment, or to continue with follow-up care after an initial visit. And these conspire to result in longer period of untreated illness, which is, the period of time between onset of symptoms and treatment. I think there's a delay in advancing here, but let's see. Okay, so similarly, we have disparities. We have disparities in perinatal mood and anxiety disorders. We also see glaring, tragic disparities in maternal morbidity and mortality. So these are the rates of illness, complications, that would be, morbidity, or death, that would be mortality around childbirth. So birthing people dying of complications related to childbirth. Okay, so very sadly in our country, we've seen increasing maternal mortality over the last couple of years. We as a country are ranked last out of 10 similarly wealthy countries, according to the WHO. And if you look at the rates amongst Black women compared to white women, and this is again of maternal mortality, so dying as a result of a complication of childbirth, the rates for Black women were 37.1 per 100,000, which is more than double what they were. This is from 2018 for white women. Black women also suffer higher rates of preterm birth, babies that are small for gestational age, and infant mortality, which would be the child dying before age 1, than women of other ethnic groups. And this is very important, regardless of socioeconomic background. And it is concluded, and there's research to support, that the stressor of racial discrimination contributes to poor birth outcomes. Okay, so this graphic is from some more recent data that initially showed overall mortality rates were decreasing a little bit in the recent year, but you can see actually the improvements were limited to only certain groups, mostly for white moms. So for white moms, the rate went from 14.7, as you saw in 2018, down to 11, so some improvement there, but for Black moms, it actually stayed the same at about 37. This chart also has a column for non-Black people of color moms, which the other graphic did not. And if we look at local data, that's national data. If we look at local data, this is from a New York City.gov press release in 2018, which announces that in New York City, Black non-Hispanic women are 8 times more likely to die of pregnancy-related complications than white women, and that this was much higher than the national average. So it's pretty stark, pretty horrible data. Some other local data, I live in Eastern Queens, and I work a lot in Nassau County, so I have some Nassau County data as well. This is data from health.newyork.gov's website, and so if you wanted to look up sort of your local data, you could go there as well. And you can see that the disparities in infant mortality rate, which is the very last row at the bottom, separated by white, Black, and Hispanic, the infant mortality rate per 1,000 births is so much higher, so many times higher for Black babies than for white babies. So this is a pretty enormous problem. Okay, so it turns out, not surprisingly, that the disparities that we see in maternal and infant mortality and the disparities that we see in maternal mental health interact with each other, right? So in 2012, Shetter published an article that, sort of summarized the evidence linking various pre-delivery stressors, such as symptoms of depression or anxiety, catastrophic events, major life events, chronic stress and racism, with worse neonatal outcomes. The outcomes that are used here are gestational age, preterm birth, and low birth weight. That's what those letters in the middle stand for, which basically are babies being born smaller and sooner, for lack of a better way of putting it. And these pathways are then associated with poorer maternal outcomes. So increase in depressive and anxiety symptoms postpartum when the pregnancy has been complicated and the birth has been complicated by these outcomes. So this can also affect that offspring's development and contribute to overall worse family outcomes. So this right here, the association of PMADs, which are more prevalent in the Black community, and racism, with babies being born sooner and smaller, and then with worse outcomes for the whole family system, represents one of multiple mechanisms by which there likely is biological intergenerational transmission of trauma. Epigenetics is another mechanism, but I won't talk about that because it's kind of off topic for this webinar, but just to explain that this is one of potentially multiple mechanisms. Okay, so if we're looking at now risk factors for PMADs, and we've commonly accepted that the items on this chart are sort of commonly accepted risk factors for PMADs, and they're categorized into, predisposing factors and then postpartum factors. I highlighted in magenta factors that the Black community are disproportionately burdened with. So we see a lot of the poor obstetrical outcomes are risk factors for PMADs, which isn't a surprise. And interestingly, having a PMAD while you're pregnant is also a risk factor for having a poor obstetrical outcome. And there are many other risk factors for PMADs that we see here are more prevalent in Black communities for varying reasons, but all ultimately connected to generations of systemic racial oppression. So these all intersect with each other, right? We could talk about how that plays out in various contexts, like housing, education, employment, but we'll try and keep it focused on birthing and family for this talk. The top box, systemic racial discrimination or structural racism. Here we're talking about things like medical apartheid, right? So the Tuskegee trials, for example, would be an example of that. If you're looking at sort of, structural racism in the blue box, gender-based discrimination, for example, isn't it shocking within the medical community that 50% of the population spends a significant portion of their lives able to become pregnant, potentially, and yet there's this dearth of knowledge and professionals or ability to have that treated? That would be an example within the medical field of what I would consider to be structural sexism, where there's an entire, huge problem that's just sort of ignored or sidelined. Now, if you were to intersect, for example, structural racism and structural sexism, that's where you would get things like James Marion Sims, who's one of the fathers of modern OB-GYN, the person who created the speculum. He did surgeries on slaves, doing repairs of tears that had happened without anesthesia. So that would be an example of an intersection within the medical field of structural racism and structural sexism. If you combine sexism with mental health stigma, you can see, for example, that there are these very old notions of female hysteria and the sort of psychological basis of pelvic pain that still has fingerprints in this day, where you do see many women who will go really long periods of time before their reports of pelvic pain are taken seriously. And instead it has been, hypothesized to be for other reasons, perhaps, psychological reasons having to do with repressed sexuality or something, rather than just sort of taking those reports of pain as valid from the get-go. Mental health stigma and racial discrimination, if we sort of intersected those two, these would be things like differences in who receives medication versus therapy for identical presentations, right? We see that, for example, when white people would present with a certain group of symptoms to a physician, they might be more likely to be offered therapy as opposed to medication, whereas when Black people would present with the same symptoms, they'd be more likely to be offered medication for the exact same constellation of symptoms. It also speaks to, for example, who gets disproportionately diagnosed with schizophrenia, Black people, versus bipolar disorder, white people. Who gets hospitalized involuntarily for fear of being a danger to others or for violent more, or even in this day and age, who gets jailed rather than hospitalized. And importantly for this population, which families get referred to CPS more often. So that would be an intersection of structural racism and mental health stigma. So given all of this, it's not really that surprising that birthing people of color are at higher risk for PMADs, less likely to report it, and less likely to continue in care. Okay, so what are the effects of illness on a person? People with PMADs suffer. They have impaired functioning, which can impact their lives, their career, their education, their relationships. The neurovegetative symptoms could potentially have short-term or long-term impacts on their health, on their offspring's health if they're pregnant. They could have some maladaptive coping skills to manage the symptoms that they're having, which could include things like addictive disorders or eating disorders. It's more difficult to care for themselves and pay attention to getting appropriate prenatal care. Certain disorders are associated with less of an ability to notice signs of labor. You primarily see that in disorders where there is psychosis. There's less of an ability to plan or prepare for the child's arrival. And of course, there's an increased risk of self-harm, including suicide. And amongst women with PMAD, suicide is the second leading cause of maternal mortality in the first year postpartum. There's some growing evidence that actually this is even undercounted, and that if we included suicide and if we included overdose and suicide, it would be the leading cause of maternal mortality in some states in the United States. Number one cause is usually a hemorrhage or infection, in case you're wondering. Okay, so pretty devastating effects on the individual. What about the effect of illness on the pregnancy and the offspring? We touched on this a little bit earlier, but having an untreated PMAD is not benign for a pregnancy. You run the risk for hypertensive disorders in pregnancy, according to some of the literature, preterm and low birth weight babies. Fetus is shown with exposure, intrauterine exposure to depression, to have a relatively increased heart rate and increased reactivity, some irritability, and some negative correlations extend out into childhood, where you see some behavioral and emotional changes by 4 years old. And there are there's an accumulating body of literature that, you know, indicates untreated PMADs have negative consequences for both in the dyad, and there are likely multiple different pathways by which these effects are communicated. And this graph sort of shows that there are multiple different pathways, some of them intrauterine, some of them having to do with genetics, some of them having to do with the ways in which the birth parent interacts with the child or doesn't after birth. I won't belabor that too much. But suffice it to say, though, that there's a profound societal impact of untreated PMADs. the birthing parent is harmed, the offspring is harmed, the family unit is harmed. It's just a travesty of loss for the future. It's a tragic disregard of potential. So in addition to the profound societal costs, of course, there's a financial cost too. Mathematica did some research and tried to analyze the cost mostly borne by employers and healthcare payers over the 5 years after delivery, and estimated that the societal cost of untreated PMADs is about $32,000 for every mother-child pair affected, but not treated. Affected but not treated. So in other words, untreated PMADs. $32,000 over the first 5 years per dyad. And as a country, just in 2017, it's estimated that this cost money-wise was $14.2 billion. Okay, so now some of the good parts, right? I'm thrilled to be able to talk about some of the ideas and projects and passion and resources that people who have really dedicated their careers to working on reducing disparities in maternal health and including maternal mental health have proposed some of the programs that are up and running. And also to talk about not necessarily programs, but ideas that have been discussed amongst this community of advocates and providers that could help to reduce these disparities. So one idea, obviously, is is screening. You know, there are guidelines for screening that generally include screening multiple times during pregnancy and screening at certain points postpartum. They're there, the guidelines are there, and many states have their own mandates, but there's enormous variability in implementation. So if we start just looking at the screening that's usually recommended, it's usually a rating scale, such as the Edinburgh. However, if we look at the way that the rating scales are capturing illness, right, and we see that actually Black pregnant people are, or perinatal, postpartum as well, are less likely to report symptoms, then one idea would be, do we have a lower cutoff for certain populations? A lower cutoff is a positive screen, versus do we need actually better screening tools that are more sensitive to across populations, or different screening tools for different populations? Should we screen at-risk populations more often? It's sort of a funny thing to talk about when even the standard screening tends to not happen consistently, to talk about doing more screening, but I think it's worth thinking about how we could sort of address these disparities at each level of interaction with these patients. So despite screening being widely recommended, barriers to actually doing it effectively include deciding where to screen. Is it going to be at the OB's office, the pediatrician's office? Who in that office is going to screen? Which professional? Are you going to have the nurse do it, the physician, the social worker? A big barrier is, once you've done the screen, where do you send people who screen positive, right? Because there's a shortage of appropriately trained clinicians to be able to treat people with perinatal mood and anxiety disorders. So that leaves the people who have screened sort of holding the bag, and it's not their area of expertise, and they don't know where to send this person. So there are some programs that have tried to address this by having a sort of consultation line for people who've screened and would like to do something but don't know what to do. This isn't really their area of expertise. So in Massachusetts, there's a program called MCPAP for Moms. It's sort of a sister program. I don't know how to describe it, maybe a child program of MCPAP, which was a program for where child adolescent psychiatrists would be working a consultation line where pediatricians or other providers could call and ask for advice on how to treat certain cases. So they could describe a case and get some feedback. This was expanded to MCPAP for Moms, where perinatal psychiatrists and experts in reproductive psychiatry work consultation lines, and OBs can call in, primary care physicians can call in, other psychiatrists who don't feel that they have enough training in specifically treating during the perinatal period can call as well. So this is a program in Massachusetts. It's funded by Massachusetts Department of Mental Health. And it also links to community-based resources when this program is used. So what if you're not in Massachusetts? PSI, Postpartum Support International, also has a psychiatric consultation line. So anybody can call that line. It's designed similarly for providers who would like to speak to somebody, a physician with perinatal mental health training and expertise to discuss cases and get recommendations. Okay, so now you've screened and you kind of have some idea of a plan, but how is this all going to be coordinated? It's still a very disjointed system, right? With you can go to this thing here and that thing there, and your OB is going to prescribe your psychiatric medication. It's not really coordinated in a sort of multidisciplinary but unified way. So there are some models that have shown some real benefit to comprehensive multidisciplinary care teams. So one of them in California is Comprehensive Perinatal Services Program. It is part of Medicaid since 1987, so for a long time already. It was designed to reduce morbidity and mortality among low-income pregnant women and their babies. And it provides, in addition to providing the OB care, they also provide a nutritionist, psychosocial support, health education, and case management. And this has been helpful. Okay, separate idea, widely discussed as a way to further reduce the disparities in perinatal mood and anxiety disorders and maternal and infant mortality and morbidity in general, is to expand Medicaid. So 50% of all births in this country are in birthing centers or hospitals that are funded by Medicaid. We know that as of, I think it might have even been a month ago already, a low estimate of 5 million people having already lost their health insurance related to the economic crisis and job loss related to the COVID-19 pandemic. And we expect those numbers to increase. Robert Wood Johnson estimated 10 million by the end of 2020, and Kaiser Family Foundation actually is saying 27 million, but they're counting family members covered under the job-related insurance plan, which seems reasonable to do, actually. So expanding Medicaid seems timely in any case. Emergency Medicaid is available for people who are pregnant. However, it expires 60 days after delivery. And this causes some problems. One, because of course, a lot of complications will happen after 60 days after delivery. So we know, for example, perinatal mood and anxiety disorders, certain of them peak from 2 to 4 months postpartum. So exactly as the insurance ends is sort of the peak incidence time for developing, especially a depressive or anxiety disorder postpartum. Another way that the sort of 2-month or 60-day expiration after emergency Medicaid for pregnancy is problematic is that it puts pressure on the postpartum person to make decisions around future family planning within that short of a time frame, and they might not be, you know, sort of ready to do so yet. So it can feel a bit coercive. You know, you have to decide by a certain date, are you going to get that IUD? What are you going to do for family planning that while you still have coverage, right? And if they miss that window because they weren't ready to decide yet, or for whatever other reason they missed the window, then they might be without effective birth control that they would have otherwise wanted, and you might end up seeing higher instances of unintended pregnancies compared with if that coverage were extended and they could seek reproductive health care later when they were more ready. Okay. Another idea that's been discussed widely is providing funding and training for community-based birthing and doula programs. So there are organizations popping up all over the place, new ones. There have been some and there are new ones that are dedicated to connecting Black pregnant or postpartum people with pregnant people with birth workers, Black birth workers, and also Black mental health practitioners to help to reduce the extra work that is often required of Black patients when they're seeing a provider who's not Black, of having to explain or justify or feel in any way additionally uncomfortable when they're already suffering. I would say that a great goal would be for providers to be able to appropriately treat people, you know, even if they were of a different background. However, it's also very understandable for people of certain backgrounds to prefer to not have to put in that extra work when they're, you know, already suffering. It really shouldn't be their responsibility in any case. So, for example, there are also programs that are specifically designed for the Black community. So, for example, Long Island Doula Association has a program specifically to promote Black maternal health that trains Black people to become doulas and then pairs them with Black birthing people. Another idea would be to support the connections that sort of develop naturally among community providers, but then sort of make it official to form coordinated multidisciplinary teams, because within communities there may often be, through word of mouth, common people that share patients, but they don't necessarily engage in a coordinated way. So it would be funding efforts to help to coordinate these more nascent or organic teams that are already existing within communities. Okay, this is actually a big one, but integrating trauma-informed care into birth centers. Given the power dynamics that we frequently see during the perinatal period, if we think back to that picture of the pregnant person in the triangle that were outlined in the previous slide, teaching and integrating trauma-informed care approaches into birth centers is a way that agency and power can be rebalanced and distributed back into the hands of the patient. Because labor and delivery is a time period where there are a lot of things you're not in control of, right? You might have pain in your sexual organs, you're not in control of that. You might not be in control of, you know, when your contractions are, or whether you're going to need an emergency C-section, although I know that there's controversy around that. You are not in control of, you know, the position that the baby is in, whether they're breech, whether they're stuck. There's just a lot that you're not in control over. And for people who've experienced trauma, this can be extremely re-traumatizing. And for people for whom there's already a problematic power dynamic with the providers in the room, and not just because the providers are, you know, physicians and therefore people of authority, but also because of racial power structures, having a trauma-informed approach very specifically and intentionally builds and encourages people to utilize agency in situations, find agency, find the things that they do have agency over, and utilize it proactively and in the moment. So Jenny Joseph is a doula who leads the National Perinatal Task Force, and she also runs a doula training institute in Florida called Childbirth Common Sense Institute. And she developed in Florida a model for birthing centers that she calls the JJ Way. Her name is Jenny Joseph. That is patient-centered, trauma-informed. Interestingly, their model, nobody is turned away, and they do serve a lot of very high-risk populations. They don't encourage people to deliver in a birthing center versus a hospital versus at home. There's autonomy and agency there as well, so people will sort of make their own decisions as they would have anyway about where they want to deliver. And one thing that was lovely when I was reading about this model is they utilize a team approach that intentionally makes use of people's nascent community support systems and notices who within the clinic the person might be gravitating towards and uses them to sort of leverage help, which I thought it reminded me a whole lot of MBT and the AMBIT model. So data that this model produced actually was pretty remarkable in actually eliminating a lot of the disparities that we see between races and ethnicities. They also compared next birth people. Okay. Another potential solution, and all of these things are not mutually exclusive, hopefully they can all be happening at the same time, spreading knowledge, right? Because one of the big factors in people not receiving care, aside from people not wanting to go get care, are people not knowing how to give care, right? So the more trainings that can be had, the more psychiatrists that can be taught how to manage perinatal mood and anxiety disorders, right? The more people that can be taught how to notice them in various settings. So training professionals, training the birthing people themselves about what resources there are and what to look for, right? Maybe they themselves can bring the PSI consultation line number with them when they see their psychiatrist who wants to stop their medication and says, hey, I know about this consultation line. What do you think about calling them before we make any decisions, for example, right? So empowering more people with knowledge and going into communities and also finding out what resources are wanted or needed, what ways of offering care, what would be helpful and what would not be helpful, and trying to do the things that are helpful and specifically not do the things that are not helpful, to build trust and align goals. So this is obviously a huge one that was going to take, it's taken many generations already, but to not ignore the fact that the structures of oppression in that triangle that I was talking about need reform in order to become trustworthy partners for care again, right? So that includes medicine, right? Including psychiatric and obstetrical care. We need to soul search and figure out what we need to do to become trustworthy partners again, which includes looking at the disparities in the historical treatment and current treatment that's disparate among populations and figuring out ways to address it. Another service that's, you know, obviously intended to be helpful and protective, it's in the name, Child Protective Services, it has been leveraged as well as a tool of oppression. Because when you look at the rates of children who've had some involvement in the foster care system by race, it's just so disproportionate. So from birth to 18 years old, 1 in 7 Native American children has been in the foster care system, 1 in 9 Black children, and compare that to a baseline rate of 1 in 17 all children. So the fear that a lot of families have of reporting symptoms and it not going well is very reality based. Okay. Other ideas have to do with legislation, right? So the Mamas Act is a bill that was introduced by, oh my goodness, Representative, why am I drawing a blank on her name? It'll come to me later. It consists of 5 components that target preventing maternal death and reducing maternal morbidity. One of the provisions talks about expanding Medicaid and CHIP. So there is a way that these kinds of changes can be made through legislation. And there's another bill summary called the Momnibus, the Black Maternal Health Momnibus, that has 9 individual bills sponsored by the Black Maternal Health Caucus members. And those make investments in social determinants of health and also try and target specific populations that are at risk. So for example, women veterans or incarcerated women. So supporting this type of legislation can also help. Okay, so with all of that, more hopeful news, with ideas and plans, I want to end with this list of leaders, resources, and organizations who have been working on increasing access, increasing care, reducing disparities for a long time. I'm sure that this is not an exhaustive list, but if you felt inclined to want to learn more about this topic or to become active as an advocate or to hear from really smart, passionate people, their ideas about how to address this, I would start by looking up the people and organizations on this list. And that is it. I made it. I finished in time.
All right. So thank you, Amanda. So if you want to just stop sharing your screen so we can take some questions,
Yes.
That would be great. All right. So some of the questions are kind of more general about perinatal mental health and some more specific to racial disparities. So one I think is very interesting in terms of your work, I guess both at Brooklyn Minds and I know some of the other clinical work that you do. How do you kind of personally incorporate a reproductive justice framework into your practice? How does that kind of come up for you?
Yeah, it's that's an excellent question, and I would say that my general stance with patients is trauma informed, always, especially perinatal patients. The perinatal time period is an incredibly culturally informed time period in terms of expectations of self, other people's expectations of them. Often people are in the position of feeling a lack of agency, even without histories of trauma. However, we certainly know that certain populations have higher instances of trauma. And so I always take a kind of shared decision-making model where a lot of the first part of the intake is information gathering. And I always discuss that based on the information, I will of course, present options for treatment and I'll let you know my recommendations. But if if you have a preference or you're not comfortable with something, please let me know, and we don't have to do that. And I don't want you to feel in any way pressured or coerced if I say I recommend something and you don't agree. So it's a lot of autonomy, a lot of supporting of autonomy, while still being clear about what the recommendation I'm making is, why, because obviously that's why they're coming to me. But tons of supporting of autonomy.
And I would say also, you know, I know you do take a number of different insurances as well, which I think allows you to treat a wider range of folks. Is that kind of common among colleagues, you would say, or no?
No, not amongst reproductive psychiatrists or perinatal psychiatrists. And actually, yes, that is certainly a way that I incorporate greater reach into my practice, because the commercially insured are sort of, ironically, an underserved population within perinatal mental health. There are some clinics that might take government-based insurances where there might be teaching hospitals, there might be some people there who are experts, but otherwise your options are generally out of pocket, and people who don't take insurance. So yeah, I do try to be available and take insurance.
Right. And I think one of the things that I really like about the work you do is you do a very thorough consultation. Can you talk about that? Yours is perinatal consultation and like what that means? Because I know you kind of have a way about it.
Yeah. I'm laughing because there was discussion earlier about how long my consultations are, and they are long.
They are long, right?
They're
For a reason. So
they're long for a reason. Yeah. So they can take really up to 2 hours. I have the luxury through Brooklyn Minds of having some information sent to me ahead of time that the patient has filled out. So by the time I see them, I have some sketch of a bit of their history and what they're coming for. But it really, I start by finding out what their goal is for this appointment. And I take a very comprehensive history, because it's true for all of psychiatry, but I will say, especially in perinatal psychiatry, having diagnostic clarity is very important. There are some diagnoses that, you know, look similar and might be misdiagnosed one for the other, and they have very different risks and different recommended treatments during the perinatal period. So taking a very careful history and being able to distinguish between, for example, borderline personality disorder and bipolar disorder, or major depressive disorder and bipolar disorder, is important. Carefully screening for OCD, and carefully screening for histories of trauma. And that can sometimes take time within the session before there's enough of a rapport to be able to broach the topic of trauma as well. I'm also finding out about, of course, medical history, family history, social history, and then spending quite a while discussing, based on all of that and the current symptoms and the goals, these are the options and these are the pros and cons of each option, and what are the risks of doing nothing, what are the risks of exposure to illness, right? So that whole spiel can take quite a while.
right, because I mean the consent discussions around medications, like speaking of respecting autonomy, like you're having to think of the birthing parent's autonomy, and they're also having to think of the baby that they're going to have and what's best, and those discussions are extensive.
Yes, they are extensive, and I find that a lot of birthing parents will come in with this notion that it's selfish of them to be in a treatment that could in any way potentially, even if the risk is minuscule, add risk to pregnancy or a future offspring. And it's a beautiful, selfless, a parental instinct, but it's really based on a false premise, because when symptoms are moderate to severe, the well-being of the pregnant person and of the pregnancy and future offspring are aligned. They're not at odds with each other, because the risk of exposure to symptoms is not nothing. It's actually greater than the risk of most of the medications, if the person were to even choose medication, that we would use in the perinatal period.
Right. And I think we don't get a ton of training as general psychiatrists in that. So I guess if you could sort of wave a magic wand, like what would training look like for the sort of average psychiatrist in perinatal mental health?
If I could wave a magic wand, I would love for there to be specific training around reproductive psychiatry in every residency training program, and not kind of perfunctory and, you know, one seminar that kind of does lip service, but actual skills-based training that was much more comprehensive. I would also want that training to include demonstrating ability to critically read the literature, because the literature is a mess because of restrictions around what kind of research you can do with pregnant women. So the literature, without being able to read it critically, might seem entirely contradictory. However, if you can read it critically and you are able to weight better designed studies over poorly designed studies, then a much clearer picture emerges in terms of clarity on what you would recommend.
Yeah, and I know this is sort of major clickbait as well. Like anytime some study comes out in this field, you'll start to see headlines, you know, that antidepressants cause, you know, all kinds of, you know, people to have 4 arms or something like that, right? And it's like it's not accurate usually.
That's right. That's right. It ends up either, you know, not being repeated in future studies, or if it is repeated, it's a much lesser risk. You know, it's you know, barely statistically significant. Also, there are some risks that, you know, might reach statistical significance but don't really have clinical significance, and those often get you know, highly publicized as well. So it's a confusing literature, and there are a lot of ulterior motives in terms of you know, maligning people with mental illness and devaluing psychiatric care as being, you know, frivolous or unnecessary, or that there aren't real risks associated with these types of illnesses. And there are absolutely real risks associated with these types of illnesses. So it's frustrating.
So I know we only have a couple minutes left, but maybe in the final few minutes, could you provide some advice on if you're the partner of a birthing parent and what they could do to support? I know someone in the audience was wondering.
Yeah. So first of all, congratulations if you're the partner of a birthing parent. It's a very exciting time. I would say that there's a lot of focus that is going to be on the pregnancy and the baby. Please don't forget to focus on the birthing person as their own independent, independently valid human being, separate from them being a vessel of birthing at the moment. And to really try and maintain that connection. And you know, as people, lots of people are going to ask, how is the baby? How is the pregnancy? How's the baby doing? Please don't forget to think about, how is my partner doing? How are they feeling? And have them not be lost in this process.
Maybe like protect her when people just go, or to go in for the belly touch, the non-consensual rubbing of the tummy action.
Run some interference there. Absolutely.
Yeah.
Unless they want that, in which case, by all means, you know, belly rubs galore, you know. Yes.
Yeah. All right. Well, thank you, Dr. Tinkelman. This was wonderful. And thanks to everyone who joined us today and asked such great questions. So folks can stay tuned for our mailings about future Grand Street rounds. And this will also be up on YouTube shortly. So thanks so much. And we hope to see you next time. All right.
Thank you for having me.
Bye-bye.